I should have started with this one because there's review cases. My bad. Okay. Just some quick diabetes case follow-up and some things to discuss quick before we get into the thyroid stuff. So this is an interesting thing that I had happen in the emergency department a few years ago. So this was a patient who showed up. She was an 88-year-old female. She came into the ED because her insulin pump malfunctions. This is actually a relatively common occurrence. Pumps are electronic, and just like anything electronic, they're prone to malfunction. They seem to work pretty well most of the time. But if somebody's on an insulin pump, based on what you know, what do you want to know about this patient? What kind of details about her case would make it helpful for you to understand how to approach strategy for how to manage your insulin care at this point? Anybody?
How often she changes the pump?
Yep. So has she noticed, like, has she interrogated her pump site? Maybe is it out? Like, is the needle like hanging out? Maybe she can't get it. Let's see. How often she checks, changes pump site. Let's say. Okay. That's a good question.
She has a history of decay.
Yep, DK history in the past.
Fasting What's her normal dosage?
Okay.
What's her normal blood glucose level?
About what kind of diabetes does she have? We assume a type 1, but is she actually type 1? You'll have type 2 people on pumps occasionally too. And what difference would that make? Right. Yeah. So if you have a type 2 patient it's not working, you have a little bit more wiggle room. Also, you can do an A1C check and see how controlled she's been on that pump too. Not as critical right now, but something to think about. So yeah, those are good questions to ask, and that gets us basically to the meat and potatoes of this case. So this patient was actually on a pump encounter, was in the chart, so her clinic had imported this stuff into their note, which is always really helpful. So one of the nice benefits of following all your care in one health system. If you go to that emergency department, you pull up that note, and then yep, you got all your information right there. So they come to me, the provider, whoever it was, and say, can you help us with this? What should we do? And so we're looking at our pump settings. Now, this can get really complicated right off the bat because you're looking at this and like, gosh, she's getting different basal rates at different hours. She's got her insulin to carbohydrate ratio here. She's got insulin sensitivity markers here, targeted blood glucose. What do I do with all this? Well, there's one nice thing at the very bottom here, which is her total daily dose, which is units. So this is something that should be reported. You can interrogate pumps too, and I'm not sure exactly. I've never actually played with one myself, but I imagine that there's processes to do this. And certainly companies like Medtronic have help desks available 24 hours for things like this. They could walk you through it if you've never done it before. So if you're working in a small urgent care or small clinic and it's just something new to you, certainly feel free to call the company. They should have a help desk available. If it's emergent, you want to send them on somewhere else probably, but if you can hold on for a minute. So the total daily dose gives them 18.8 plus or minus 1.2 units per day with their percent basal and percent bolus they're using. That's really helpful if we're looking at a malfunction pump and we're like, how do we replace this person's insulin throughout the next couple of days until they can get a new pump? And that's the other question you have to ask yourself and the company, the patient, and whoever else you're working with to get a number of opinions on this. But if you have a diabetes specialist in-house, I'd get them involved in the case too because they can work with the pump as well. But if this happens I think this was like, 8 o'clock on a Saturday night or something. So of course, right, no one like that is around. So we have the opportunity to learn here, and we talked about a couple of different options. And so this is just really an exercise in exploring the scenario and how you could approach it. So this patient was actually a type 2 diabetic, so that made a difference. And you could probably tell that her total daily insulin isn't huge. And, you might think, why would a type 2 be on a pump? Well, she got onto aggressive insulin management at some point, just because orals weren't working for her. Maybe she had absorption issues. Maybe she just wasn't getting the numbers she needed. It's not uncommon to have somebody be on a pump just because it's easier to manage than multiple injections. So if she's tolerating it well, it could be a really good option for a type 2 diabetic. So don't rule out pumps totally for type 2s. So the solution we could come up with, and the doctor wanted, the MD I was working with wanted me to come up with a couple different options for him. And one I had was that we could look at her total daily dose, look at her basal, and look at her mealtime and develop some sort of a strategy, get her insulin pens. Who knows if she's used insulin pens recently and if she would know how to do that. It's probably going to require some counseling and education on our part. So quickly getting complicated. Or we could simply look at giving her a somewhat, well, I say somewhat appropriate, but an estimate of basal insulin and tell her to inject a couple shots of Lantus over the next 2 days until she gets her next dose. And we talked about the pros and cons of having her doing mealtime and sliding scale. We looked at her current blood glucose, which was actually pretty good. I think it was like in the 200s. It wasn't high. And we decided to go with that route versus going with a complicated sliding scale mealtime dosing. So let's be simple here. Let's give her something that she can work with, something that's relatively easy to understand, and not overcomplicate the situation. And Medtronic could get her a pump. I think it was like Monday morning. So it would just be 2 or 3 doses of insulin. We told her to monitor herself. She knew how to do her blood sugar testing and everything like that. Make sure that if she starts to creep up too much that she could come back in and would have that resource available. But again, just taking a step back and realizing you don't have to overcomplicate it in all scenarios. Now, if it was a DKA situation, 500 above an emission or a glycemic hyperosmolallic state, that'd be a different story. That might require an admission. This patient doesn't need to be admitted. She can go home with an insulin pen. She doesn't need to be monitored. But she should just be aware, or if she has a caregiver or family, they should be aware to keep an eye on her for the next several couple of days, and then into her new pump, making sure all that stuff goes smoothly. So sometimes when you're working in situations like this, like urgent or emergency care, you get these snapshots of patient care and you don't really see the follow-ups. It's important to know how best you can interject yourself without overreaching. And I think if you make a really complicated insulin regimen, I don't know if that benefits the patient at that time. Now, they might need that at some point if they can't get a new pump or something like that on Monday. Something doesn't come in the mail or whatnot. But at this point, I think that was the right decision to make. So we talked about the different options, and that's where we went with it. So again, if you couldn't get it for 2 weeks, that was something that would be, 1, get a new pump company, so that's pretty bad. 2, that would be a strategy where, okay, let's maybe get you bridged to a clinic appointment on Monday and get you to see a diabetes specialist, and they can go over something with you. Or, if you felt comfortable, you could set them up with something more comprehensive at the initial visit. But again, urgent care, emergency medicine, focus on small interventions that are going to get the patient to where they need to go at the next phase in healthcare. That's kind of my model. So I don't like to monkey with stuff too much if I don't have to. Okay, diabetes question 1. Here's a softball question for you. Which of the following medication regimens would be preferred to start in a newly diagnosed type 1 diabetic patient? C. Yeah. Okay. So none of the other options apply to type 1 patients. They're all type 2. So this is what type of drug is this? Remember? No. It was like, we haven't memorized those acronyms yet. What are you trying to do? So it's a GLP-1 or a glucagon-like peptide. And then we first got metformin. So metformin is not going to work in a type 1 patient. So again, easy question hopefully there. All right, question number 2, a little bit more confusing, purposefully. So I would never give you a question like this on the test, so let's make that clear right away. But it gives us the opportunity to talk through a couple of different scenarios. So we've got MT, he's 46-year-old male. He has hypertension and type 2 diabetes, diagnosed, started on metformin. He has been working on improving his diet, exercising more. 5 months of these changes, A1C today is 8.7. So what would be the best option for him? Now, out of these choices, technically all of them, with the exception of 1, are correct. So which one is not correct? Which one is different than the others? Choice D. Yeah, so what would his A1C goal be, or generally speaking? 7, 6.5, depending on what you're looking at, yeah. So he's above goal. So even though he's been working on his diet and exercise, you can give him a pat on the back, tell him good job, keep going. but we want to maybe manage your therapy a little bit more aggressively here. So he's on metformin. So if I was going to give you a test question, I would preface this end statement with something else. Like, you could do basal insulin. You could then add on a SLGT1 transporter. You could do glipizide. All of these three are okay per the ADA guidelines. But if I was going to give you a question, I would lead you in a little bit more of a direction. Like, I might say he has kidney dysfunction or something like that. And let's say I say his serum creatinine is currently, or his creatinine clearance is currently 30, and he has mild renal disease. How would that change the picture? Would that rule out any of those therapies? B, yeah. So B is going to only be a drug for people with healthy kidneys. If I said something about cost, potentially, that's a big deal with diabetic medications. Do you guys know which one's been around the longest? And which one's a newer medication that might be more expensive? Yeah, so sulfonylureas have been around for quite a while and are generally going to be quite a cheap oral hypoglycemic alternative compared to a lot of the other ones we've talked about. So if cost was an issue, that might lead you to glipizide. If I said he's really opposed to injecting something and I gave you a bunch of, like, maybe instead of glipizide I gave you insulin, canagliflozin, and then I gave you one of the GLPs like exenatide. So that hopefully would lead you towards not using an injectable product. But I'm not going to tell you they're injectable. You just have to know that insulin and the GLPs are injectable products. So those are the type of things that I want you to know. I'm not going to give you something this vague with 3 choices that all work. So hopefully there's enough in the question for you to be able to tease out what I'm trying to get at. Diabetes isn't a straight line. There's a lot of choices you can go down, and it really depends on the patient. And even with some of the specifics, there's still maybe a few good choices that would work. So that's where it gets complicated to test on it. But I'm going to try and get to those specifics of the medications that I think are the big ones to remember. Okay, so with that being said, let's take a quick break, and we can come back and talk about thyroid. Let's do 5 minutes. All right, so hypothyroidism is pretty easy because there's basically one drug. Yeah.
How come you can give insulin to type 2 diabetics if their body's not responding?
It's insulin resistant, so the theory is you just give more and it works. So sometimes you'll see type 2s on really high doses, like hundreds of units a day. And that's just to try it. The idea is you give enough, you can overcome some of that resistance. Yeah.
Is it possible to be like 100%?
I don't know. Yeah, it's a good question. Yeah. Hopefully not 100%, because then you don't really have any options. A lot of orals, I guess, at that point. All right, so hypothyroidism, it's a disease that is relatively easy to treat, I think, and it's got a pretty set amount of symptoms associated with it. So some of the ones we're looking at are going to be just slowing metabolism in different ways. Weak heartbeat is one that people can see, dry, cold skin, cold intolerance, sometimes mental health type things like depression, irritability. Schizophrenia would be hopefully not associated with hypothyroidism. I think this little graphic calls it in quotation marks because you could get some, in severe cases, some schizophrenic-like symptoms where you're getting hallucinations and paranoia. But hopefully that'd be reversible if you treat it. We're looking at a couple of different things with thyroid and thyroid hormones. And our biggest biomarker we like to look at is thyroid stimulating hormone. That's because as your thyroid can't produce as much T3 and T4, your body upregulates production of TSH. And so if you're looking at somebody's labs and you see a really high TSH, that's a sign that they're probably hypothyroid because their body's trying to push out more, their thyroid's just not producing it. And T3 and T4 have a couple of different roles, which we'll talk about here in a second. The other thing I just want to mention as far as the mechanism goes, because we'll talk about iodine here in a second, is iodine intake. And the dietary iodine is required for thyroid hormones, T3 and T4 synthesis. So if you're iodine deficient, which usually isn't a problem because iodine's added to most salt people ingest, but if you're sea salt only type of person and you don't have any other added salt in your diet, which I think would be very hard to do, but if you are, dietary iodine can be potentially hard to come by. So just making sure people are supplementing it if they're low. But usually it's honestly really not an issue. Most people have no problem keeping their iodine up. It's possible though. Overview. This is usually permanent, common, lifelong condition. It's probably one of the most commonly prescribed medications. I think actually levothyroxine is one of the highest frequency prescriptions in the country, if not the highest, outside of maybe some like acute pain management medications. It's more common in much more common in women than men, and more common in older women. Sorry, that's a typo there. Therapy is relatively straightforward, so we're usually going to replace the missing hormone. Goal of therapy, we want to restore our thyroid function, and the symptoms of hypothyroidism will resolve. So it's actually a pretty straightforward disease. We're just replacing the missing hormone, monitoring for labs, and making sure that the patient's symptoms are being managed appropriately. Some factors that increase requirements for T4, so things that might change acutely in different stages of life that might not be applicable for the whole person's lifetime. So this might be things that could be changed. Like, for example, if somebody's pregnant and they get some hypothyroidism during their pregnancy, that might resolve postpartum. Estrogen therapy, so if they're taking estrogen therapy during a perimenopausal period, that could be another thing that increases requirement for T4. There's some other things listed on here too. Some drugs increase catabolism, which could possibly increase the need for a therapy. Not really common, any of those drugs, but these four are always thought of as like the hallmark enzyme inducers, so they just metabolize things quicker. And then some malabsorption issues potentially as well. So levothyroxine itself is just synthetic T4, and Thyroid or Levoxyl are the two brand names. There's a couple other ones out there. Thyroid was the first one to come out, and it's the one that's most commonly associated with levothyroxine use. This was one of the few examples in medicine where a lot of people stick to their brand name and don't switch generic. The reason being is because it can take some effort to titrate somebody's thyroid dose in to the point where they're steady on it. And you can see, I just put a screenshot up of the different products that come out. There's a lot of different doses out there. So you can titrate these very specifically. You can give half tablets. This is another medication that you might see people taking different doses of on different days to get to a total weekly dose that's enough for them. So you might see these little variances in people's dosing. And the idea is if you switched from, let's say, Thyroid brand to Levoxyl brand, the potency could be off even by a couple percent. That could throw your whole regimen off completely. So a lot of times you'll see people say, well, I have to have brand name Thyroid. And this is one of those few instances where most places still stock brand names of the products, even though there are generic versions of levothyroxine out there. So if you have a new patient, start them on the generic, and then they can manage it off that generic product, and you aren't going to have any issues. But it's just when you switch brands, you go into problems potentially. Synthetic T4, so that's what this is. 80% is absorbed via the GI tract. T4 gets converted to T3 outside the thyroid, T3 being the active form. And that's the one that is used. So that's something you can do levels on to see what people are producing and how much synthetic or how much T4 and T3 they have. That can be another way we can diagnose and look at a hypothyroid picture. But for the most part, this is just synthetic T4. And your body ideally will be converting this as it needs it. So the difference between giving a bunch of T4 versus a bunch of T3, if you gave somebody a bunch of T3, their body has the active form available to them all at once, where T4 I think of the body as sort of being able to manage its resources that way and push it through to T3 as it needs to have available. It's a once daily dose that has about a 6 to 7 day half-life. So if you miss a dose of your thyroxine, or your levothyroxine, you aren't totally out of luck. Your levels are going to dip a little bit, but you still have a fair amount that's going to stay in your system for a while. And again, a lot of different doses. The other thing that's interesting about the way these tablets are made is the only other drug I can think of like this is warfarin, where across all the different brand names, the colors are the same. So if you have a patient on the green ones, well, I guess there's two different green ones, so they get kind of confusing because some of them look the same. But let's say they're on white. White's always going to be 50 no matter what brand they have, and that's a specific way that this drug's manufactured. So at least if you do switch brands, the colors will be familiar to the patient. Again, very common chronic med, probably one of the most common out there. There is also an IV form available too, which you could give to people if they're NPO for some reason, or if they have a hypothyroid issue that's exacerbated by some sort of acute illness that you want to supplement. It's an option. Dosing is usually started at 1.6 mic per kilo per day. So like a 70 kilogram adult would be 112 mics per day, which is why there's a 112 microgram dose. You might be wondering why there's some odd doses here, like there's an 88, a 112, a 137. Yeah. Somebody thought that that's more convenient than the standard like 100, 125, those types of things. But I don't know. Anyway, you'll see the odd dosing here, but that's what that was based off of. Older adults are usually going to start a lot lower than that, and a lot of patients you might start them lower because they might not need all of that to get up to where they need to be. And you can titrate levothyroxine reasonably quickly over a few weeks, so you could increase their dose if they're not getting symptomatic relief. But usually you're going to wait 2 weeks to see the full symptom resolution. If somebody fails, it's really simple. You just increase the dose. If you get to a really high dose and somebody's not responding, we'll talk about a couple other options, but for the most part, you should be able to manage them with levothyroxine alone. You can check TSH once yearly, once your dose is established, and this may change based on some of those factors, like in 6. So if your patient gets pregnant or goes on estrogen therapy or something like that, it might increase the need for a dose change, but otherwise, you're looking at being pretty stable for most patients once you dial in that dose. That's the most challenging part, is getting them on the right dose that works for them. Once you do that, it should be pretty consistent. Outcomes: long-term therapy is highly effective and essentially resolves this issue. So we can't cure the fact that your thyroid's not producing it, but we can supplement it to the point where there's not really any interruption in how your body normally would have thyroid available to it. Side effects usually just have to do with over-treatment. So you give too much thyroid, you get hyperthyroid, and hyperthyroid has some complications associated with it, which we'll talk about in a couple slides here. The other option is synthetic T3 or liothyronine, or Cytomel is the brand name. It's generally not recommended to be used for hypothyroid. It's very short-acting, it's got rapid absorption and rapid onset. And so whereas T4 is kind of like a nice delayed approach, it gets into the body, it gets used as appropriate, T3 is a spike. So really, we aren't seeing this used in this instance. Where they do use T3, we'll talk about very briefly and as an antidepressant adjunct. So there's some evidence that people who even have normal thyroid labs will respond to synthetic T3. And I don't know if it's just because it's the active form or what, but they don't respond to T4. So sometimes as an adjunct antidepressant, but it's relatively rare. It's not something you're going to see a whole lot. And we'll come back to that during psych. T4 measurements are not helpful when somebody's on synthetic T3 because you can't really tell how they might not be converting their T4, so you don't really know. It might be their body might be producing some, but if they have like a high T4 level, you're like, oh, their T4 looks good, but they're taking T3. Well, it might be because their body's not converting that T4 into T3 then. So it kind of interferes with the way you can do lab monitoring for hypothyroidism. Really, where this is useful is if you have somebody who's on a really high dose of levothyroxine and not getting use or not getting benefit, switching or adding on the liothyronine can be beneficial. But that's really the only situation in the hypothyroid case where you're going to see that happen. It's really difficult to replicate physiologic levels by giving some combination of both, which you theoretically might be able to do, but it just doesn't work as well in practice as theoretically it might sound. The other product out there, which is rarely used, is Armour Thyroid, which is a desiccated thyroid produced from cow and pig thyroids. It's a natural product if you want to view it that way. And you might get patients actually who prefer it because they don't want the synthetic version, they want the natural version, whatever. I think it's kind of gross. It smells really bad. Mostly T4, but it's some T3. It's dosed in grains, which is an old school way of dosing things. One grain contains 60 milligrams, so sometimes you'll see things dosed per grain, or like 1.5 grains or whatever. But basically, one grain contains 38 micrograms of T4 and 9 micrograms of T3. And just to equivalent, it takes about 36 micrograms of T4 to convert. It's about the same potency as 9 of T3. So one grain is about 74 micrograms of T4, which theoretically responds more like 88 in clinical trials. Anyway, when they do clinical trials, they put Armour Thyroid up against 88 micrograms of plain T4, and people get similar results. So how you come to that is it's a little bit convoluted, and I don't fully understand how T3 gets equivalent to T4 when T4 gets converted to T3, but that's the way they justify it somehow. The only people I really see on this are A, people who want this product because they think it's more natural, which is a small amount of people, and B, people who have been on this product for a really long time and they don't want to switch or don't need to switch because it works for them. This product is actually it might be less expensive for some people, but it's not cheap. The way they produce it isn't like making synthetic drugs with a bunch of powder in a big vat in a lab somewhere. They actually have to source biologic material for this. So, and granted, they're desiccating it and putting it into a tablet, but it's a little bit more of a complicated process than your standard drug development. So it's not necessarily the cheapest drug out there, but it could be less than brand name Thyroid for some patients. Okay, treatment, easy. T4, and if that doesn't titrate your dose, that doesn't work, add T3. Simple, right? That's pretty much it. Watch your labs. Really, again, the challenge is getting your T4 dose to the correct level. That's where you're going to run into the most issues with this. Yeah.
So I get picking like a starting level, but then from there, you go up a certain amount.
Yeah, I think what I see commonly done is like 25 microgram increases. So, and whether you want to start somebody at one of those weird intervals is up to you. But I think if you start at a multiple of 25, it allows you to titrate a lot easier based on the availability of products. So.
And then is it like every 2 weeks that they?
Yeah. Every 2 weeks you could do a little bit more aggressive if you started low. Like let's say you were really worried about hyperthyroid. Maybe they're just kind of on the border and you don't want to be aggressive to start with. If you start them on just maybe a really low dose, like 25, you could titrate them up a little bit more quickly, like every couple of days. Yeah. But really to get to steady state, you're looking at a couple of weeks. So it depends on how fast you want that symptom resolution to occur. But yeah, so you're still going to see, but you can ramp them up a little bit quicker, especially if you're starting with a low dose, because they're still going to go through it faster. Yes.
For the starting dose, it says young apprentices, so is there a percentage to decrease?
Yeah, I don't think there's a specific example. I'd say with the elderly, I would start with some of the lowest product you can get and then just work your way up slowly. Yeah. There's not really specific guidelines, but a lot of them will sort of start at 25 or 50 micrograms and then work your way up from there. So
is that what we're not known?
I don't know. It's a good question. I think that was a general rule of thumb that came out. I don't know what their age cutoff was. But what I see done now is it's a more conservative approach. So they'll just start somebody and work them up slowly. Yeah. So I'm not going to test you on that mg per kg starting anything like that. So don't worry about the dosing. All right. Hyperthyroid's a little bit more complicated. So it's the opposite set of symptoms. Usually you're looking at high metabolism. Tachycardia and systolic blood pressure are two ones we want to watch out for because they're going to cause probably the most devastating consequences. If you get really hyperthyroid, you can end up in a thyroid storm situation that's life-threatening. Basically, it's like your body's going into cardiogenic shock. And that's just a comparison. Causes of hyperthyroid. People who have There's a couple of different ways you can get this. So first of all, radioiodine uptake is one possible source of hyperthyroid. So it depends if you're normal or high radioiodine uptake or very low or absent. Somebody with normal radioiodine uptake would be people with autoimmune disease, autonomic tissue, or TSH mediated. And usually these are related, these next two are going to be related to different types of cancers. So we have different adrenal gland tumors or pituitary tumors, which makes sense that that's going to interfere with the way that your body can process iodine and can make your thyroid available to process iodine. You know what I'm talking about? I talk about radioiodine uptake, by the way. So you give somebody contrast media that's radioactive iodine, and you see if it goes into their thyroid gland. You can see that on imaging. If it doesn't, or if it does, or if it's good intake, it looks normal, these are going to be your causes. If it's low or absent, if your thyroid's not taking it up at all, it's going to be something like this. So if you aren't getting radioiodine uptake diagnostically, thyroiditis is something that's usually caused by either excessive radiation therapy, somebody that might have like a upper cancer, possibly throat cancer, something like that, or amiodarone therapy actually causes that as a chronic toxicity. So we talked about that last fall. Or excessive replacement therapy. Somebody who's been overdosed on T4 for a long period of time can exhibit this, or even a lot for a short period of time potentially. But you have to get a pretty high dose to get there. Graves' disease, I put a celebrity up here. Missy Elliott has Graves' disease, apparently. I learned this once when she was doing the Super Bowl a while ago. Somebody said, I think she has Graves' disease, and I Googled it, and sure enough, she does. So there you go. Fun fact. So anyway, Graves' disease is the most common cause of thyroid, hyperthyroid that's not directly related to something else that you can. So it's not like a tumor or some sort of radiation therapy. This is something that is a different type of autoimmune disease. It creates antibodies against the TSH receptor. Treatments are generally focused on two different aspects. So the first is symptom resolution. So tachycardia and blood pressure, which are going to be elevated. We're going to look at beta blocker therapy, which can correct the tachycardia. Can also help with some of the things like anxiety and heat intolerance, which are also likely due to that psychomotor uptake that's causing the reflex tachycardia. And this is sort of a bridge to something else. So eventually we want to get somebody on a more controlling medication, but this is something that can help with the symptoms. Atenolol is one of the ones that's recommended and studied, but theoretically any beta blocker would be fine. Thionamides we're going to talk about on the next slide, and these are going to be for more moderate to severe disease only. And things I'm not going to talk about, radioiodine therapy and surgery would be other options to get people corrected who have Graves' disease and are having complications from it. Thionamide drugs, the goal is to give these and attain a euthyroid state in 3 to 8 weeks, and usually this is followed by some sort of ablative therapy, so either radio or surgical. So eventually somebody is going to do something to shut this thyroid gland down at some point, and then the person's going to take T4. But in the meantime, we're going to try and get them down gradually. We don't want to cause any overcorrection right away. It may take 1 to 2 years to achieve remission without additional interventions. So without giving somebody, if you just gave somebody a thionamide, you can end up getting to a point where their thyroid gland shuts down completely over time. But usually if you can get them to an ablative therapy sooner, you're going to end up with better outcomes. So again, that's sort of the goal, is to bridge them to that. So again, we have a couple different bridges here. We have our symptomatic bridge, which is our beta blocker, then our bridge to a more aggressive therapy, which is going to be our thionamide. So what these drugs do is they inhibit synthesis of thyroid hormone by blocking oxidation of iodine in the thyroid gland. So it limits your biosynthesis of T3 and T4. Circulating T3 and T4 will still be functional, so it will take the body some time to metabolize those out, but you won't be making any new ones. Methimazole is the preferred drug here. It's got a long half-life. It reverses hyperthyroidism more quickly than its friend propylthiouracil. And it's usually got dosing guidelines based on how severe the symptoms are. So more severe disease, higher doses. PTU was the older drug. The difference is that it's okay in pregnancy. So if you have a pregnant patient that needs a thionamide, PTU is preferred. Otherwise, methimazole is going to be preferred in all your patients. PTU is dosed 3 to 4 times a day. It's not quite as effective either when compared to methimazole. Toxicity. Common side effects: itching, rash, arthritis, fevers, abnormal taste, nausea and vomiting. Lots of not good side effects. These aren't the most pleasant drugs to take, and people don't tolerate them all that well. Yes.
So you said that the PTU is okay in pregnancy. So would you say that women that get this in childbearing age or something, you would want them to be on PTU until they?
Yeah, I think it depends on how long you plan on having them on it. So are you going to do some sort of surgical or ablative procedure coming up, and then what their family planning is. But yeah, if they're planning on starting a family soon, I would go with PTU over thionamide. Thionamides are over methimazole. Methimazole is proven teratogenic. So if there's any chance, I would definitely use PTU. Yeah.
So are you saying we don't use methimazole long term in humans? They always do the ablation to knock out the thyroid?
Always, I don't know, but I don't. Typically, yeah, it's not a long-term drug. Right. Okay. Yep.
It's just a bridge until you get that.
Yep.
Okay.
Yep. Agranulocytosis is a rare reaction that can occur. That's where you wipe out your white cells pretty much completely, so your immune system shuts down. It's really serious. You have to do a lot of CBC monitoring to make sure that you don't get that. Immune-related vasculitis is another thing that's seen. Hepatotoxicity. Okay, so going on and on about all these side effects. Just know, don't really care that you know every single one, other than the pregnancy thing. And just note they aren't very well tolerated medications overall. There's a whole laundry list of side effects with them. Iodine therapy is something that's kind of has an interesting niche in these patients. So you have solutions that are designed to be used medically, and they block the release of T3 and T4 from the thyroid gland within hours of administration. And they usually peak, as far as their effect goes, 10 days after treatment, or after 10 days of treatment. We don't use iodine as much anymore because our thionamides and our radiation therapy have pretty much replaced it. However, for short-term use, it can be helpful in some cases. Like a preoperative Graves patient, sometimes they can use iodine to decrease thyroid vascularity and risk of thyroid storm. The reason being is because it's going to block the release of T3 and T4. So if you have some T3 and T4 still circulating or possibly still being produced before you're going to do that, you can block that hopefully and decrease some risk going into surgery. So it's something that's an option. Otherwise, one thing to consider is start methimazole before you give iodine, because iodine can actually be used by the body as a supplement to make more T3 and T4. So you have to balance that out and make sure you're doing it appropriately if you're going to give somebody iodine. But start your thionamide first. All right, thyroid storm. So the severe complication, potentially rare, life-threatening, long-standing untreated hyperthyroid, usually precipitated by some kind of an acute event. So surgery, trauma, infection, acute iodine load, or labor can cause thyroid storm as well out of nowhere. Otherwise, you're looking at somebody who's been treated, probably over-treated again for their thyroid for a long time. Symptoms, standard hyperthyroid, just amped up. Remember, cardiovascular is the biggest concern here. IV beta blockers can be used and given to control your CV-related symptoms. We do give propylthiouracil every 4 hours, I think because it comes IV, but I'm not 100% sure on that. It also has a bit of an additional mechanism that's more beneficial in this case, where it blocks T4 to T3 conversion, where methimazole doesn't do that. So it will stop your body from converting more T4 to active T3 at a rate that methimazole can't compete with. So there's a better use for it in this situation than for like a standard chronic hyperthyroid. Potassium iodine can be added to IV fluids. You get negative feedback on hormone secretion. We just talked about iodine's role there, so you could incorporate that here. Glucocorticoids can also decrease T4 to T3 conversion. And ultimately, you're going to transition somebody to methimazole once they're stable to prevent this from recurring. But in the meantime, you would, or PTU, hopefully if they're in labor, they've delivered at this point. But if they still, maybe they went into pre-labor and then they stopped, who knows, you'd want to use PTU, of course, if they were still pregnant. So that's basically it with thyroid storm.
Well, I understand. So why does iodine?
Right, so you have to make sure you've got the thionamide on board first. If you don't have the thionamide on board, iodine won't be effective. So iodine is going to block release of T3 and T4. If your thyroid's still working, it can use the iodine to do it, but otherwise it's going to block any release of remaining T3 or T4 from the thyroid gland. Okay, a couple quick things. Pituitary-related hormones, there's not much to talk about here from a medication point of view. We're going to touch base on a couple of these things during the women's health module. I've got some fertility drug slides as well. And some of this stuff plays into therapy there much more so than talking about it randomly here, so I'm not going to bring it up. And there's a couple of other things that I'm not going to test you on here. So these are kind of just slides that I don't know why I have them on here anymore, but they aren't really anything I want to talk about as far as the disease state. There's a number of different diseases out there that have different hormone effects, and we can treat some of them with different drugs. But again, they're odd, they're kind of rare. Usually, if we're going to do anything, it's going to be treating symptoms, a syndrome of inappropriate antidiuretic hormone, which is too much vasopressin, by blocking vasopressin with a drug that does that I'm, again, not going to talk about. Or diabetes insipidus, which would just be giving synthetic vasopressin to promote that. So again, I don't care that you know this. It's not going to be tested on. If you want to look into more of that, you can. But again, they're just not, I think, worth our time to go into detail on. So hopefully I didn't disappoint any of you guys, but that's that. I think just because I can't get through the whole men's health lecture in 25 minutes, I'll punt it to the summer, so we'll cover it. So you guys get a little break from me there. How's that?